CICU devices.
Understanding the Impella 5.5. Key concepts for clinicians. For more insights on Impella device, we recommend you to visit our Impella Guide playlist on the CICU Devices channel. The Impella 5.5 is a temporary catheter-based, microaxial left ventricular assist device. It is designed to provide short to intermediate-term mechanical circulatory support in patients with severe left ventricular failure. The device is capable of delivering forward flow up to approximately 5.5 liters per minute, thereby directly unloading the left ventricle while maintaining systemic perfusion. In comparison with smaller, percutaneously inserted Impella models designed mainly for short-term support during high-risk percutaneous coronary intervention, Impella 5.5 is specifically approved for longer duration use, up to about 30 days in many protocols, and is particularly suited to patients in whom extended high-flow support with the possibility of ambulation is anticipated. The Impella 5.5 operates via a microaxial pump driven by an electric motor. Pump speed is measured in revolutions per minute and typically ranges from 0 to 33,000 revolutions per minute, depending on the performance level selected. Flow output is not fixed for each P level. Rather, it is preload dependent and sensitive to afterload. The primary physiological objective of the Impella 5.5 is mechanical unloading of the left ventricle. By aspirating blood directly from the left ventricle cavity and expelling it into the ascending aorta, the device reduces left ventricle end diastolic volume and pressure. This results in decreased wall stress according to the law of Laplace, which states that wall tension is proportional to intracavitary pressure and chamber radius. Reduced wall stress lowers myocardial oxygen consumption and may promote recovery in stunned or ischemic myocardium. Simultaneously, forward systemic flow is maintained or augmented, thereby improving end organ perfusion. This physiology contrasts with that achieved by veno-arterial ECMO support, which increases flow and mean arterial pressure, but does so at the expense of raising afterload, reducing myocardial perfusion, and increasing oxygen demand. In contrast, when Impella 5.5 support is combined with veno-arterial ECMO therapy, it counteracts the deleterious effects of ECMO by reducing afterload, improving myocardial perfusion, and decreasing oxygen consumption, as well as preventing the development of acute pulmonary edema. The device also incorporates fiber optic pressure sensing technology and smart assist algorithms that continuously estimate flow, cardiac power output, and ventricular unloading parameters, allowing real-time hemodynamic monitoring and optimization. The Impella 5.5 consists of several structural components. The inlet area, positioned within the left ventricle, which aspirates blood. The cannula, a plastic conduit that facilitates blood transport from the inlet area to the outlet. The outlet area, positioned in the ascending aorta, which expels blood. The microaxial pump impeller. The catheter shaft, that contains the motor drive cable, the fiber optic pressure sensor line, and the purge line. The purge system delivering heparinized solution to prevent blood entry into the motor housing. And the external automated Impella controller, which regulates pump performance and displays hemodynamic parameters. The system is intended for patients experiencing cardiogenic shock, post-cardiotomy failure, or advanced heart failure requiring temporary mechanical support as a bridge to decision, bridge to durable LVAD, or bridge to cardiac transplantation. On the other hand, Impella 5.5 contraindications include mechanical aortic valve prosthesis, severe aortic regurgitation, severe aortic stenosis preventing safe crossing, presence of LV thrombus, significant ventricular septal defect, severe peripheral arterial disease precluding access, and uncontrolled coagulopathy. The Impella 5.5 is typically implanted surgically via graft anastomosis. This approach allows patient mobilization and longer support duration. The most common access is the right axillary artery, but alternative approaches include left axillary artery, direct ascending aortic insertion, or in select cases, the innominate artery may be considered. These upper body access approaches reduce the risk of lower limb ischemia and facilitate patient mobilization and ambulation during mechanical circulatory support, compared with femoral approaches that typically require prolonged bed rest. Regardless of the graft anastomosis site, there are different options for externalization, which the surgeon can select based on the patient's anatomy and the team's preferences. Correct positioning of the Impella 5.5 in the left ventricle is critical for optimal function and avoidance of complications. Echocardiography, either transthoracic or transesophageal, plays a central role both during implantation and in subsequent surveillance, complementing fluoroscopic guidance. These are the main anatomical landmarks. The inlet area should be positioned approximately 5 cm below the aortic valve annulus. Depending on patient anatomy, it should be free-floating within the LV cavity and avoiding contact with the interventricular septum or papillary muscles. The outlet area must remain above the aortic valve within the ascending aorta, ensuring unobstructed forward flow. Malposition may result in suction alarms, hemolysis, inadequate flow, or aortic valve injury. Finally, continuous reassessment with echocardiography is recommended after implantation and during clinical changes.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.